everyone. Let's start our session today. So today, these two lectures would be the final lectures that I would give. Tomorrow, we are going to do a lot of USMLE type questions together, similar to what you were doing in the small group. The difference is that I have picked those questions or have made those questions in a way that you are exposed to some new material. At the same time, not everything is new, so it's kind of a practicing what I have said over these 4 days. At the same time, once in a while I introduce a new concept, so hopefully you will enjoy it as much as I enjoy doing questions. So today we are going to talk about chronic kidney disease. Many of the diseases, many of the pathologies that you have talked about, you have heard about, will end up here. This is like you have a lot of rivers and then there is a lake. That many of these rivers end up in this lake or in this sea. For example, yesterday in the small group, we were talking about acute tubular necrosis. There are three different phases, recovery, whatever, but not everybody recovers. So what happens to those who don't recover? They end up with chronic kidney disease. Or they are exposed to some medicines, they get acute interstitial nephritis. Okay? Some of them will recover, some of them will not. Those who do not recover will end up with chronic kidney disease. Chronic kidney disease is the final destination of those with a variety of kidney diseases who do not recover. Acute cell nephritis, glomerulonephritis, acute tubular necrosis, and so forth. Okay. So I wanted to share with you this. This is Besançon in France. This is where I actually did my nephrology training for the first time. And think about it, I always am wondering if it was my destiny to become a nephrologist. So this is the downtown, right? This part is the downtown. Do you see this here? What does it remind you of, this kind of a picture? Does it remind you of anything nephrologic? Nephrologic. Isn't it here? Isn't it a glomerulus here? Right? So this is, if I don't know if I can make this cursor work. Yeah. So you look at here, this is the urinary space, right? This is the glomerulus. This isn't it the Bowman space here, the urinary space? This is the vascular pole, and this is the urinary pole, right? Always think about it. It was my destiny to become a nephrologist when you go to live in such a place. Anyway, so let's start with a case like always. Mr. Paul Smith is a 65-year-old gentleman who has been referred to you for evaluation and management of chronic kidney disease or CKD. So the first question is, what is CKD? We know that it is chronic kidney disease, but you need to have a definitive definition so everybody will be on the same page. So here is what we know about definition of CKD. This is something we need to memorize. We need to know. There are two ways to make the diagnosis of CKD in someone. Number one is evidence of structural or functional kidney abnormalities that persist for more than 3 months. Let's say tonight somebody has an accident, no problem whatsoever, no past medical history, goes to the hospital, and because he has belly pain, they do a CT scan of the belly. They see that for all his life he has had one kidney, he didn't know. From tonight, he is chronic kidney disease because structurally he has one kidney instead of two, right? It's as easy as this. Or somebody has proteinuria. When I have proteinuria, it's a functional abnormality of the kidney. More than 3 months, CKD, right? Evidence of a structural or functional abnormality of the kidney for more than 3 months, CKD. Does that make sense? Okay. But actually, this is the one that nearly only, I would say, 5% of CKD is diagnosed this way. The easier way or the other way of making the diagnosis, anybody with a GFR of less than 60. If my GFR is less than 60 for 3 months, CKD. Do you remember this 60? I told you the first day that we are going to get back to this. It was here. So if I have a GFR of 100, good for me. If I have 110, even better. If I have 90, is not a big deal. 62, I am not CKD. 59, I have chronic kidney disease. Does that make sense? And do you remember when I showed you that table where with the aging our GFR was coming down? I mentioned to you that it comes down physiologically, but it never goes less than 60. We do not physiologically get chronic kidney disease. Does that make sense? Perfect. Okay, so our patient, we look at his medical records, and it shows that Mr. Smith had a serum creatinine level in May 2012 was zero point 0.9. 6 years later, 1.3, 1.9. So it's been an ongoing process, going little by little, the creatinine is going up. You remember creatinine, when the level goes up, it means the filtration is coming down, right? Okay, you remember that. And you remember that the normal creatinine, we say around 1. So do you remember the MDRD equation? We said that it is based on age, gender. I put race in parentheses because we don't use it anymore, and serum creatinine. This is the formula. And you remember what I said here? I looked at this lady and I said she's unhappy because she doesn't have any muscles, right? Okay, so here we are. Then we said that MDRD used to be the most commonly used method for evaluation of renal function. Now we need to go with CKD epi without race. Just let's refresh what I told you yesterday. For the general population, CKD epi creatinine does the job. For patients with CKD, we prefer to do CKD epi either with cystatin C or cystatin C and creatinine. Do you remember? This is what I was talking about. As we age, our GFR comes down, but never goes less than 60. Physiologically, we don't get CKD. So, do you remember we talked about CKD-EPI being a calculator? You can Google it. You can put CKD-EPI calculator, 2,500 calculators come up. I use the one that is from National Kidney Foundation. They're all the same. And it has creatinine or cystatin C, age, gender, and then you calculate. So for this patient, we put serum creatinine is 1.9. Age, we said he's 65, and we said the gender male, right? That's all we needed, these three things. And the calculation is here. It gives us a GFR or an estimated GFR of 39 based on CKD epicreatinine. 39 he has, right? So now we know that Mr. Smith serum creatinine was high, but we wanted to pinpoint what is the estimated GFR. Now we know that it is 39, and you know that the unit is milliliter per minute per 1.73 square meter of body surface area. Okay, but just like any disease, there is severity that we have. We have breast cancer, stage 1, 2, 3, 4. For the CKD also, we have stages that we say how bad it can be. So these are the stages of CKD, and it is 1, 2, 3, 4, 5, and 3 is divided to 3A and 3B. And it is not really rocket science. If you look at the numbers, it goes by 90, we come to 3A and 3B, it becomes 60 to 45, or 45 to 30, and 30 to 15, and less than 15. They go by 15 or 30. You may want to familiarize yourself. I'm not sure you need to exactly know the whole table, but you need to have an idea. When I tell you the his GFR is 39, is it really bad or not? No, it is in the middle, right? 39 that this patient has. Where is he standing? What would be the stage of Mr. Smith's CKD? The GFR of 39. Say something. You don't have to be correct. 3B. I agree. Very good. Okay, this is another way of looking at it. I want to tell you something to trick you a little bit, to make you think about it. So, when you have pancreatic cancer, breast cancer, whatever cancer, stage one, two, three, four, typically stage one is more common than two, then three, then four, right? Typically, we get to the later stages less often. Okay, if you think about the prevalence in the millions here, something that draws your attention all of a sudden is that actually what is more common is stage three, more common than stage one, more common than stage two, and definitely more common than four and five. How come? How kind of a disease you have that the one in the middle is the more common one? Right? Do you see what my question is? Why the most common stage is right in the middle, not at the beginning, not later? Why would that be? What do you think? They get diagnosis later? It might be. It is true. Yes, the majority of the cases that are diagnosed are within the stage. That is true. But the question is why? Right? It is true. What you say, it makes sense. The majority of people that are diagnosed with chronic kidney disease are stage three. That's why the prevalence is the highest. But my question is, why is it the case? And it is so silly you wouldn't believe when I tell you the answer. The answer is the definition. I just told you that the definition of CKD, there were two definitions, and I told you this one is the one that most cases are being diagnosed with. When you have a GFR of less than 60. So all of a sudden, stage three would be, because if you go back, look at here, stage three starts when you have GFR of less than 60. Then you ask yourself, what is the stage one CKD? If you tell me that I have CKD only if my GFR is less than 60, but you tell me here that stage two CKD are those people who have a GFR between 60 and 90. So somebody who has a GFR of 75 can't have CKD. Think about it. It's the other definition. Do you remember I told you if I have one kidney, I have chronic kidney disease, no matter what my GFR is. So my GFR might be 100 and I have one kidney. In that case, I have stage one CKD. I might have 3 grams of proteinuria and my GFR is 89. So I still have stage 2 CKD. Does that make sense? So one definition is by GFR, one definition is by abnormality. Stage 1 and 2 are for the abnormality one. Because the one that is by GFR, it starts with a GFR of less than 60. I hope I didn't confuse you. If you didn't get what I just told you, you don't need it for US70. It was just to understand why stage 3 would be the most common form of chronic kidney disease. This is why, because the diagnosis is starting from here for most patients. Okay, we said that he's 39, and so he would be a stage 3B CKD. It's written at the top. Okay. So you inform him that, hey, Mr. Smith, you have chronic kidney disease, stage 3B. The first question he will ask you, why do I have it? Why did I get CKD? What are the causes of chronic kidney disease? You see this big thing, forget about the numbers. What you need to know from this slide is this. The most common reason for chronic kidney disease worldwide, and especially in the United States, would be diabetes, followed by hypertension, and the rest is not important. CKD, diabetes, hypertension. And you know, at my time, there was a competition between diabetes and hypertension. One year it was more common hypertension. Now you are all good. Diabetes is by far the most common. In my clinic, I sometimes forget to ask the patient if they have diabetes or not. I just ask them how their diabetes is controlled, because pretty much everyone has diabetes who is coming to see us for chronic kidney disease. Okay, so everyone deserves a diagnosis. It's a little bit preachy. When in doubt, no long-standing diabetes or hypertension, there might be a need for further investigation, such as checking the free light chains. Free light chains for what disease? What disease do we check free light chains for them? Yesterday in the small group, we had that. What was it? Was it multiple myeloma? Yeah, multiple myeloma, multiple myeloma. Yeah, you guys know it, but you're too shy. Say it. Don't worry. I don't ask people because I hated when I was sitting there and somebody told me, "Hey, you tell me something." I hated that. But you try to say it. If you are wrong, that's why you are here. Anyways, and you use here. I wanted to make sure here you understand that to rule out multiple. I had written here multiple myeloma. Anyways, one thing that you and I we need to use our common sense. If somebody comes to me, he has chronic kidney disease that is very advanced, but he was diagnosed with diabetes only 2 years ago, and it's been very well controlled. I'm not sure diabetes is the reason for the chronic kidney disease, right? We need to use our common sense. But if I have a patient who has had 20 years of diabetes, not so well controlled, A1C has been in the range of 8, 9%, and now comes with CKD, 99% I'm sure that it's the diabetes that's the cause. If I'm not sure, I have to do a biopsy. His past history, Mr. Smith, 20 years of diabetes, 10 years of hypertension. Okay, very well. So what do we do about this? What could have been done for Mr. Smith, basically, what I'm saying? What I'm saying is that normally we need to screen people, but you ask yourself, who should I screen when I go out to, let's say, you have a health fair in Dominica, and you tell them, I want to screen people for chronic kidney disease. The first question they will ask you, whom do you want to screen? Everybody, or there is a specific population that are at risk? You want to focus on them so you don't waste your resources. This would be the answer. Like everything, when I give you a big list, I tell you which parts are important. The ones with the arrow are the ones that you need to know. Hmm. In other words, those with diabetes and hypertension are at risk. You really, if you want to screen for chronic kidney disease, these two groups, no matter what, you always do it. Then people who have a family history of chronic disease, it is so, I don't say it is funny, but it is quite impressive. I go to my dialysis unit and I'm talking with him and say, did you know that my sister is in the other unit in town? Did you know that my cousin is that guy sitting there? So it runs in the families, if you think about it. Have have you had ever a glass of water drops from your hand and it shatters? There are some pieces of glass that are really at the moment, and as you go farther, there will be less and less. So if I have CKD, my first degree people are more likely to have chronic kidney disease. It's one of our main questions when we see a patient for the first time. Okay. And another one, US ethnic minorities. We have still remember what I told you. Race is not a biology construct, it's a social thing. But you remember that when we go there, we do see a lot of black patients. It is socioeconomic, it is genetic, it is whatever. You need to do screening for them based on the recommendations. Perfect. So these are the ones that you will screen. So I told you whom to screen. But then you ask me, how do I screen? What are the tools for screening these people that you told me? Here is the answer. Again, a big list. I tell you these ones that are you need to know. So those you check the blood pressure in any health fair. I'm sure that you check their blood pressure, obviously, right? That's one of the first things. Then serum creatinine to estimate GFR. Based on which formula do you go for in 2025? In a health fair. So it is not for patients with disease. You're going out and you go for CKD epi. I think it's a good idea. But would you use CKD epi creatinine or cystatin C for the whole group? creatinine. The name goes with it, epidemiology. Okay, very good. And then you check the proteinuria, spot urine, spot. Do you remember the numbers I told you when assessment of renal function? I had a slide about it. Less than 30 milligram of albumin per gram of creatinine is normal. 30 to 300, it is called microalbuminuria. More than 300, this is called macroalbuminuria or proteinuria. Okay? It is not the type of protein is inside albumin versus other proteins. It's the amount of protein. Okay? So, if you screen the patients and the patient meets the definition of CKD, we talk about it first. If it is not, no risk factor reduction. Basically, you tell them low salt diet, healthy lifestyle, physical activity, and all those, not to get CKD. This is preventive, right? They haven't met the diagnosis, the definition of CKD. But if they do, then we need to know what stage of CKD they are, what is the cause, the risk factors for progression, because I can have CKD. Okay, so what? My job from today is not to let it progress to end stage kidney disease, not to get to the level you need dialysis, to keep it the same way it is. If I keep CKD where it is, at the end of the day, it's a number. But if I let it continue to progress, I haven't done a good job. And last one would be to identify the comorbidities. So R for Mr. Smith, I put all of this for you. We said that he has stage 3B. What's the underlying cause? We said that he had major diabetes and hypertension prolonged. The risk factors are proteinuria for him. We haven't gotten to this. We are going to get to this proteinuria, and we are going to explain why. And obesity. We think that he might be obese based on his BMI. Okay. Diabetes is so prevalent in patients with chronic kidney disease that even you can classify CKD based on diabetic, non-diabetic. Non-diabetic is some of the diseases you were talking about yesterday in a small group: glomerulonephritis, chronic interstitial nephritis, AKI that does not recover fully, partially recovered or not recovered AKI. They all become non-diabetic kidney disease. Diabetic kidney disease, the name goes with it. Okay, the non-diabetic kidney disease, these are the examples, and you already know about all of them, right? All you need to know from this slide is not all of it. The ones that are the top: glomerular disease, vascular disease, tubular. These are the three compartments, the structure of the kidney, basically. Each of them can go wrong. It can give you chronic kidney disease, and the other one is diabetic kidney disease. Okay, so that, what are we going to do? We talked about Mr. Smith. We talked about the staging. We talked about whom to screen. We talked about how to screen. So the next question is, what are the goals of CKD care? When a patient with CKD comes to my office, these are the four things that I have in mind each time. First is to prevent cardiovascular events. As much as I am a nephrologist, a patient with chronic kidney disease, when he comes to see me, I am thinking about his heart. I can't do much about the GFR. What I can do is to keep him alive. Letting him die with good GFR would not be a good goal. To prevent or delay progression of CKD to end-stage kidney disease, to prevent complications of CKD, and to prepare. We are going through these, each of them, a couple of slides. Number one, to prevent cardiovascular events. You see, I put this above progression of kidney disease. As a nephrologist, I am more worried about his cardiovascular disease than how his GFR will be 3 months from now. So number one, and why is it this? Because I have this diagram in my mind. What this diagram is telling you is that these are the GFRs and this is the mortality, cardiovascular mortality. It tells you that As our GFR is going down, our mortality goes up. But more important than this, you will see another diagram that will blow your mind. So, what does that mean? It means that I am going to be aggressive with cardiovascular risk modification. If for you and me, an LDL of 100, 110, 120, it's okay. Just less burger, more physical activities, whatever. In a patient with CKD, I am super aggressive. I bring down the LDL to less than 100. And actually, if I can, I will push it to less than 70. Super aggressive with chronic kidney disease. Chronic kidney disease is an established cardiovascular risk factor. You just saw that diagram. The less my GFR, the higher my cardiovascular mortality is a major, major risk factor. So for this patient, for example, review of his labs show an LDL of 143. So I give him a statin, a cholesterol lowering medication, let's say simvastatin. Okay. The second, so we talked about preventing. The second would be delaying the progression of kidney disease. So now I have this GFR of 39. How can I keep it 39 for the next decade instead of 39, 37, 31, and going down? How can I do that? Okay. For that, we need to know what increases the rate of GFR decline. We have two different factors. Some of them are non-modifiable. We need to know it, but we can't do much about it. A man is more likely to progress than a woman, for example, male gender or older age. If I diagnose it at the age of 80, it is more likely to progress compared to somebody at the age of 35. Okay? African Americans, probably true, but we are not sure. I just put a question mark with a race on it. Okay? But more importantly is the modifiable ones. This is something you need to tattoo in your brain. You need to know this. The four of them, especially the ones that are in red, the two major factors for progression of CKD, proteinuria, hypertension. We should be big on treating this. If we want to keep the GFR where it is, the patient should have major, major treatment or control of blood pressure and proteinuria. Obviously, if they are diabetic, they should have great diabetic control. And smoking, when a patient comes to me, I have a lot of reasons to counsel against smoking, cardiovascular disease, coronary. We can say on and on and on. But as a nephrologist, I have another motivation to tell them because I will tell them if you continue to smoke, your GFR continues to go down. It's your choice. Heart, brain, stroke, everything, we know that. But for the kidney also, progression of GFR decline will be increased if I continue to smoke. But again, if you want to remember only two, it would be proteinuria, hypertension. These two you really need to remember. These are the factors that increase the rate of GFR decline. Okay, I went here. So we asked him to smoke, Mr. Smith. So hypertension, I told you yesterday, just let me remind you, hypertension has a special relationship with CKD. It can be a cause or a consequence of CKD. We said that hypertension and diabetes are two major causes of CKD. Now I can tell you that it is also a complication, meaning that I was normotensive, but now that I have chronic kidney disease, I have become hypertensive. Okay. I put the goal 140 over 90 and I write next to it 130 and over 80. Again, we went through the details of it yesterday, enough not to emphasize, right? You remember GNC8? Just to refresh. Everybody would be 140 over 90 except for those who are older than 60, do not have CKD, do not have diabetes. Do you remember that? And again, this is JNC8. I personally do not agree with it, but we need to have some standard to start with. Most nephrologists, based on AAC guidelines, they go with 130 over 80. Last night in NEJM, there was a paper that came out, 120 actually was the systolic, and it was associated with better outcomes. So again, that I don't think this will ever resolve. At some point in your practice, you will pick one number and you go with that because every day there will be a new number. Okay. Why do we think that hypertension is important to control, to avoid progression of CKD? Because of this diagram. It tells you, and again, forget about the numbers, 107, whatever, whatever. The point is, if I have better control of blood pressure, my renal survival, meaning that my GFR stability will be better compared to somebody who has high blood pressure. The renal survival starts to come down, the blue line. So physical exam shows that our Mr. Smith's blood pressure is 151 over 88. He has a sedentary lifestyle. He's counseled on increasing his physical activity and following a low salt diet. Do you think between low sodium and high potassium diet, which one is more important? Very, very good. Both of them are super important, but if you want to give one recommendation only, one banana a day, one pineapple a day, whatever potassium a day might be healthy. Okay. Proteinuria. We talked about two major factors that increase the progression of CKD. One was hypertension, we just talked about. Second is proteinuria. You remember these again, these numbers you need to memorize. Proteinuria increases the rate of progression of CKD. Normal for you and me is less than 30 milligram of albumin per gram of creatinine. 30 to 300 is called microalbuminuria. More than 300 is called macroalbuminuria or proteinuria. We need to remember this. So one of my jobs is to use medicines to bring down proteinuria to help avoid progression of CKD. Does that make sense? This is the diagram I have in mind. The less proteinuria, the better renal survival. Again, renal survival means stabilization of GFR, right? The less proteinuria, the better. Forget about the numbers and all those. The concept is important. Oh, I don't know. Each time goes by two. Okay. Now you see, I told you about the staging. I said it is based on GFR. It starts from 90, 60, 45, 30, 15, and right? Now I'm telling you something added, which is more recent. So GFR is here. Again, the same concept, 90, 60 to 90, then 3A3B, then 15 to 30, and less than 50, right? But then they added A, so I can have G2, A1, G2, A2, G2, A3, less than 30, 30 to 300, more than 300. You see that? We added another thing because again it tells you what how severe is your kidney disease, and you know the darker the red the worse shape. So G5 A3, higher rate of mortality, the most severe form of CKD, has a lot of proteinuria and the GFR is less than 50. But the best one would be when the GFR is not low and there is not a lot of protein in the urine. This would be the perfect one. So this is just for you to know. Obviously, you are not going to memorize everything, but you know that the staging of kidney disease now has not only the G, which is the GFR, but it also has A, which is albuminuria categories A1, A2, A3. You need to know which one it means, what it means, each of them. So now that we know this, we just said Mr. Smith has 3B, but we didn't know how much albuminuria he has. Do you think we can check his random urine albumin, random urine creatinine to see what is his exact stage of CKD? Let's do it. Here is a real case. So I put it here from our hospital so you can calculate it. Can you calculate it here? It is 185 and 80. So albumin in the urine is 185 and in creatinine is 88. So do you think our albumin to creatinine ratio is around 2? Do you think it's a good idea? Is it 2? 2 milligrams per gram of creatinine, the ratio? That's the trick. Do you remember I told you in nephrology, pay special attention to units? Look at the units here. And this is our hospital. I didn't try to trick you. It is just a tricky. This one is milligram per liter. This one is milligram per deciliter. Unless you make them the same units, then make the ratio, you will be completely off. Okay. So I decided I take this 88.5 and change it to milligram to gram per liter, and I tell you why. 88 milligram per deciliter would be you divide it by 1000 to make it gram per deciliter. So divided by 1000 would be 3 digits going back to make it gram per deciliter. But you want it per gram. Remember the units that I told you was milligram of albumin per gram of creatinine. Do you remember that? Milligram of albumin per gram of, if you go back to those slides, you will see that that was the unit. So by making it gram per liter, and up there I have milligram per liter, the liter with liter will get canceled and will be milligram per gram. Again, now it might be a little bit too much, but when you are at home tonight, take a look at it at your own time. You will see what it means. At the top should be milligram, at the bottom should be gram. That's the whole point. You need to change the units on your own. But you know, the reality that urine albumin to creatinine ratio would have been 185 divided by this number, 0. So it would be, why do I go this way? Or is it? Oh yeah, it is. Mr. Smith's microalbuminuria would be 209 milligrams per gram. You see, it has been given it to us. I had just be hiding it for you. Right? This was here. 185 divided by 81 would be 2. But if you change to the right unit, it gives you milligram per gram of creatinine would be 209. And based on A1, A2, A3, do you know 200 milligrams per gram would be A1, A2, or A3? Let me remind you what it was. Less than 30 is A1. Less than 80 is normal. 30 is normal. Basically, you and me, we should have A1, all of us. Then 30 to 300 was A2. And then more than 300 was A3. Do you remember that? Okay. So this one would be A2 or A3 or A1. A2, would you agree? Between 30 and 300. Okay. So he has 209 milligrams of albumin per gram of creatinine. So he has microalbuminuria. So he would be, if you ask me, what is his stage of kidney disease? I will tell you, and I have written at the top. G3B A2, meaning that he's here, G3B, because his GFR was 39. You do remember? G3B A2. He's staying here. Is he in a very good shape? He's red. Not that red at the bottom here, but he's red. So this is a patient that you need to keep a tab on. Okay. A word about diabetes and the kidney. We talked about the fact that those two, proteinuria, hypertension, are main factors for progression of CKD. But we also said smoking and glycemic control are also important in progression. If I have a patient whose diabetes is not well controlled, his CKD will continue to progress. That's basically the point. We try to make the hemoglobin A1C on the low end around 6 to 7%. So review of his labs showed that Mr. Smith has a suboptimal control of glucose level. It has been 10.4%. He's referred to an endocrinologist and a dietitian. Okay. One thing I wanted to remind you of is that, do you remember yesterday when we were talking about CKD and hypertension? When we came to CKD, I told you patients are started on ACE inhibitors. First choice, all other people thiazide. Do you remember that? And we said nephrologists love ACE inhibitors, and I told you I will tell you why. This is why. Why ACE inhibitors and ARBs are good for CKD? Because they bring down the blood pressure. We knew about it, that these are antihypertensives. But more importantly, I put it in red. They bring down the intraglomerular pressure and protein filtration. So what does that mean? Everybody, please look at me. We have the afferent arteriole bringing us the blood. This is the glomerulus, and this is the efferent taking the blood out. Are we good so far? Afferent coming in, glomerulus, efferent. Are we good? Okay. Let's think about it for a second. If we have a medicine that opens up both afferent and efferent, but this one is not opened as much as this one opened. So the blood is coming in, this one is fully open, and the blood goes out. Do you think the pressure inside the glomerulus will go down or will go up? The blood is coming here, stays here, goes out. Both of them are open, but this one is fully open compared to this one. The pressure inside will be down or will go up? Will go down. There is not a lot of resistance for the blood to go out. It's all open. So the blood is going out freely. So the pressure here will fall. The pressure was coming from the blood coming in, coming, going out. It was like a round place that it was just this is glomerulus basically. So by opening this one a lot, you bring down the intraglomerular pressure. That's why ACE and ARB do. That's why we love them so much, because we think it's not all about the systemic blood pressure. Calcium channel blockers do that. Beta blockers do that. But what they do on top of systemic blood pressure is that inside the glomerulus, they bring down the pressure. That's why it is a healthier glomerulus over time. Does that make sense? For us, the lowering of intraglomerular pressure is even probably more important than the systemic hypertension. Does that make sense? So you ask yourself, how do they do it? Why do they open both of them, but this one opens much more? Interestingly, it has something to do with the number of receptors that are on the efferent arterioles, which are much more than on this side. So the drug will act much more on the efferent side than the afferent side. Okay. So this is what I was trying to tell you, the blood flow coming in and then this one going out. And then we need to know that angiotensin 2 on its own gives you fibrosis and proliferation. So by stopping that, you cut down on the fibrosis in the kidney. Technically, what I'm trying to say is that we nephrologists are in love with ACE and ARB. Even the patients that do not have proteinuria, we try to use them. So a patient with CKD who needs something to, if their blood pressure allows, we always put them on ACE or ARB, right? Basically, if the blood pressure is not too low. So in this patient, we started him on losartan, which is an ARB, angiotensin receptor blocker, 50 milligrams per day to help with hypertension and proteinuria. He had microalbuminuria. Do you remember? 209. Okay. So we talked about the prevention, complications. So what are the complications of CKD? I mean, are they a lot? Yes. I just picked a few of them. Remember, hypertension can be a complication of CKD, can be a cause of CKD. So I put it number one and super big. Then anemia, hyperkalemia, metabolic acidosis, hyperphosphatemia. Yesterday we talked about AKI. When you don't filter enough, your phosphorus goes up, your potassium goes up. This is just common sense. You don't have to think too much about it. And I talked about acidosis yesterday and the day before. Metabolism generates hydrogen, generates acidosis. So one part of the function of the kidney is to counter metabolic acidosis. If I have chronic kidney disease, I am prone to have chronic kidney disease, metabolic acidosis. Okay, these are the numbers for Mr. Smith. Potassium is 5.7, so he has hyperkalemia. He has bicarbonate that is low. He has hyperphosphatemia, and he has anemia. Anemia and CKD, something you need to know. They will always ask us, what is the reason for anemia in CKD? It is erythropoietin deficiency because erythropoietin is made by the kidney. Do you remember the first day I told you everything parallels filtration, all the functions of the kidney? If my GFR is coming down, all other functions are coming down, including my ability to produce erythropoietin. So I am prone to get anemia. Okay, the goal of anemia is 10 to 12. We don't normalize hemoglobin. It has been shown to increase mortality. You want to do a USMLE question? It is a real question. I didn't make it up. That's why it has so many distractors. God bless their heart from A to J. Okay, 32-year-old woman, type 1 diabetes, progressive renal failure, or the past 2 years. This is an old, it's not renal failure, it is progressive chronic kidney disease. She has not yet started dialysis. Examination shows no abnormalities. Her hemoglobin concentration is 9. Hematocrit is 28, and MCV is 94. The blood smear shows normochromic normocytic cells, doesn't have all kinds of genetic diseases that give microcytosis. Which of the following is the most likely cause? I let you read and see what you come up with. If anybody knows the answer, please let me know. A, B, C, D, E, F, G, H. Which one would you go for? You go with that. Okay. Somebody goes with D. Does anybody want to go with something else? Just see how many options they gave. Took us half an hour to read the options. I think I agree with her. Yeah, B is a good answer. Erythropoietin deficiency. The main reason for anemia in chronic kidney disease is erythropoietin deficiency. Very, very good. Excellent. So, hyperkalemia is also important because of low filtration. We tell them low K diet and we give them diuretics, loop or thiazide. And now we know that thiazide can give us hypokalemia, despite the fact that they work on NCC that doesn't affect the potassium. Do you remember the discussion yesterday? You owe me the explanation for hypernatremia and loop diuretics, right? Did you guys think about it? The small group people? I'm 100% sure you can say it, but we'll give it a try today. Okay. So I give them these handouts. It says high potassium diet. I give it to them and say, hey, try to avoid taking a lot of these. And you see, all healthy foods are here. So patients with CKD, basically, we tell them not to eat healthy food that has a lot of potassium in it, and we tell them to get these ones have acceptable. So these are also healthy, but they have less potassium in it. So we will give them a handout when they are in our clinic. In terms of metabolic acidosis, it's easy. We give them bicarbonate. They have the choice of getting baking soda. Very difficult. I don't know. Anybody has tried to eat it? If you haven't, don't. It doesn't sound like a good idea. So most people will choose the pill, but some people still use it with some juice. Okay. Hyperphosphatemia is important, can lead to elevated parathyroid hormone. I don't go through it because on its own, it's a whole chapter. But we have secondary hyperparathyroidism in patients with CKD. The reason is that the phosphorus is high, so PTH goes high to push this down. But that is another story. One thing you want to know is that, do you know the sodas can be, I would say, dark or not dark? The dark sodas are dark because of their phosphorus. So we tell them, if you want to enjoy soda, don't go with dark sodas that have a lot of phosphorus in them. So Mr. Smith prescribed erythropoietin for anemia, hydrocortisone for hyperkalemia and hypertension, bicarbonate for metabolic acidosis, and a binder of phosphorus. These are some pills you eat. It goes, binds to the phosphorus in the GI tract, doesn't allow absorption of phosphorus, goes back into the stool. So we call them phosphate binders to bring down the phosphate in the serum. So these are what we gave him, and we gave him an appointment, and we told him to come back in 3 months. So a word on dialysis and transplant very quickly. Our second session is shorter, but this is just very quick. To prepare dialysis and transplantation, timely transfer is important. So the point I want to make here is this, that any patients that has chronic kidney disease and it progresses to what we call end-stage kidney disease, the GFR is less than 15, stage 5, so we need to prepare them for dialysis. At some point in their life, then they will start in this cycle and will stay in that cycle for the rest of their life. They are either on hemodialysis. At some point, they might get lucky, they get a transplant. For many years, they have their transplant. It fails, they can come back to peritoneal dialysis or go back to hemodialysis, and then in this cycle. So basically, this is the destiny of any patient with chronic kidney disease who gets to the level of end-stage kidney disease. But what is end-stage kidney disease? That will be our lecture next hour. Thank you so very much for your attention.